From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the Web and Social Media Editor, here today talking about variation in postoperative outcomes across federally designated star ratings. My guests today are Dr. Adrian Diaz from The Ohio State University.
Hi, thank you for having us. It's a real honor.
And Dr. Andrew Ibrahim from the University of Michigan.
Great to be here and always great to collaborate with a fellow Ohio State colleague.
I would really love to start out by hearing about the origin story of this particular project. We have so many measures that are out there of value and quality of care that I immediately was led to wonder why you thought it was important to look specifically at the CMS hospital star ratings.
Thanks for this question. It really gave us the opportunity to kind of look back at the origin of the study. So really it was twofold. One, as you alluded to, plenty of researchers try to elucidate hospital quality and value and do a myriad of rankings and measures to try to help elucidate better hospitals from worse hospitals on whatever outcome they may choose. But in particular, CMS about 8 years ago took this upon themselves and developed the star rating system that we referenced several times in the article. And then about 3 years ago, they updated and revised the original ranking system. So it was a topic that many folks, both in the policy and research realms, were interested in looking at and seeing how effective it was being. But also CMS was starting to talk about transparency, not just from price transparency, but quality transparency. And many of the tools that they were developing and then putting out for both researchers and patients to utilize to help them figure out where the best place for them to receive healthcare was. So with that in mind, we asked ourselves, is this really a tool that beneficiaries of Medicare could utilize to figure out where the best place for them to have surgery might be? So with that in mind, we ventured on answering this question.
And I'll add one more layer to that story. Oftentimes when we get an article reviewed, 2-3 reviewers, we initially groan a little bit and then we look through and say, hey, they made a lot of good points. We probably should think about that. So a previous paper that Adrian and I wrote that's in JAMA Network Open tried to tease out this question of if patients have variable outcomes after surgery, is it the neighborhood they come from or the hospital they go to? And one of the reviewers really pushed us to say, you really have to think about a measure that a patient might actually use to choose a hospital. And we sort of realized that actually public-facing CMS star rating is one of the most available to patients and most plausible for how they might choose their location of care. So thank you to reviewer 2 from a couple papers ago. We don't often say that, but that also helped move us in this direction.
I think that's a terrific origin story for this study, and I think that's such a great thing for young investigators to hear in terms of where a really fantastic idea comes from. For this particular work, you used the MedPAR database, and I wanted to just have y'all say a little bit more about the advantages and disadvantages of using that data for the analysis.
Yeah, so the MedPAR data comes from Medicare. It's Medicare beneficiaries. So the biggest benefit is that it captures 100% of Medicare beneficiaries having the surgeries that we looked at in this particular study. So that was coronary artery bypass, colectomies, hernia repairs, cholecystectomies. So we were able to capture 100% of those at every hospital across the country. And that was important because we were comparing hospitals to each other and based on their star rating. The other benefit that it's Medicare beneficiaries, and this is, Medicare measure, the star ratings are developed by Medicare or CMS rather. One of the negatives or the drawbacks of this data is that because it's Medicare beneficiaries, we only capture patients that are 65 years old or older. So we certainly are missing a younger population. And then in terms of insurance status, again, we're limited to just those that are insured by Medicare. So we're missing the privately insured. We're missing patients that might be insured by Medicaid. It's a very large sample size, nearly 2 million patients. So we have no reason to believe that these findings would not be reproducible in a different cohort.
And I'll just add one more of the trade-offs. There's no question we are in an era of unprecedented data availability. Our clinical registries are getting bigger. Our private data sources that we have access to are getting bigger. However, for as large as those data sets have gotten and as granular as they've gotten, Medicare remains one of the only data sources that you can identify the hospital where patients got care. So many of the other clinical registries by societies, for appropriate reasons, don't want you to identify the individual hospital. So this is actually one of the only national databases where we could isolate that to compare their star rating directly.
And let me ask a quick question as a point of clarification. It is only traditional Medicare that is included in the MedPAR database. It does not include Medicare Advantage plans, correct?
That's correct. And it's an important point because Medicare Advantage is certainly growing, but we lose some data granularity in terms of patient level information when you try to include Advantage.
When I was working my way through the findings that you all have from your analysis, certainly the text was well written, but figure 1 is really, for me, the high yield presentation of your findings. It was a super efficient way for me to understand that the key finding from your analysis was really the amount of variation that was present. And I wanted to know if you all were surprised by the amount of variation that was present for essentially all major outcome measures for each hospital star rating.
Yeah, just to sort of describe the figure briefly, the figure ranks the hospitals along the x-axis based on their risk and reliability adjusted outcome, and then the outcomes on the y-axis. So the hospitals with better outcomes are on the left-hand side, and then as the outcome worsens, the hospitals move towards the right, and you get this S or sideways S-shaped curve. So to answer your question, I think we were a little bit surprised. We expected some variability. I think anyone who studies outcomes and hospital quality expects a little bit of a variability, but the amount of variability, nearly 2 times the variability or double the outcomes across every single star rating system, I think was pretty surprising. I would have expected that as hospital star ratings improved, the variability probably would have narrowed, but that's not at all what we see. The variability is very consistent across every star rating system.
In full transparency, Adrian developed the figure, so it's his genius. But I want to add one more layer to why I think it's so brilliant. To the eye of the beholder, you can get a lot of things out of that figure. And one of them is if you're a CMS administrator and you just looked at the average within each star, you actually see a beautiful gradient that as star rating goes down, mortality goes up. And if you only looked at what we presented in the figure of just the average within the stars, you would say, hey, this star rating tracks really well. And on a population of averages, it does. But what the figure really isolates is that there's so much variability within each of the categories. I actually thought it was going to go straight across, and I thought there wouldn't be any correlation. So the fact that there was some was surprising to us based on just how much we know about variation in surgical quality. But ultimately, the variation within each star rating is far more than those across them.
And while we're digging a little bit into these figures and what they demonstrate for us, I know we discussed in an email exchange the supplemental figure, which I'm going to encourage our readers to please pull up the supplemental figure. I think that there's really important information there too. And I would love for you all to talk a little bit about the issues with the star variation and geographic areas that are highlighted by that particular figure.
Yeah, so it goes back to the crux of the impetus for this study, and is, can patients use this star rating to reliably shop around or pick a hospital where they should have surgery? And figure 1 is great because it shows all the hospitals, the nearly 4,000 hospitals we looked at in the study. But that's not how patients pick a hospital. Most patients live in a geographic area and they have a handful of hospitals, 3 to 5 hospitals probably, that they could reliably, realistically travel to. So to sort of isolate or mimic that experience for a patient, we looked at the top 20 metropolitan areas, the most populous metropolitan areas. And individually, we looked at all the hospitals in each metropolitan area and asked ourselves, if a patient in this metropolitan area were to pick a hospital solely on CMS star rating, would they make the right choice by picking the highest star hospital? And what we found was actually the most surprising finding to me, that in only about 10, so about half the metropolitan areas that we studied, would the right choice be the highest star rated hospital. In the other half of the areas, you would be better off having one of these 5 operations at a hospital that was, say, a 3 or 4 star rating rather than the 5-star rating hospital. And for me, that was really the most surprising finding from the study.
I wanted to dive a little bit into health equity for just a minute, because you introduced the issue of health equity in the results with the mention of the fact that the proportion of Black patients receiving care at one-star hospitals was highest, and that this showed a stepwise decrease. My sense is that this is an important finding, and I certainly know that it adds to existing literature. And what I wanted to try and ascertain from you all is if you feel like there are practical ways to identify structural barriers that may exist for both minority patients and the hospitals that serve a high proportion of minority patients.
Yeah, it's a really important question. And as you alluded to in your question, we're certainly not the first study to point this out. There's been others from Dr. Dimmick to Dr. Metzen to Dr. Bonner in this very journal who have highlighted the disparity in distribution of where patients are getting their care. So in many ways, our study validates and is consistent with those prior studies that were purposely set up to investigate that question. It was a finding from our study that was notable and we highlighted in the discussion. And I think what we're seeing in the findings is the fact that these star ratings are generated from a myriad of metrics, and some of them are directly outcomes, but others are hospital resource metrics. What services are available at a hospital, or what the staffing at a hospital might be, or what the age of certain capital investments of the hospital might be, all go into play into these star ratings. So it very much is an indirect measure of resources of these hospitals. And I think in some ways we're seeing why some populations like the Black patients and Hispanic patients and other minority patients are disproportionately seeking care at some of these hospitals that might be in communities with older hospitals or hospitals that are less resourced.
One of the concerning patterns that comes up in this phenomenon, it's described by Dr. Dimmick, I think probably 15 years ago, and we've seen it repeatedly, and I'm sure it would be the same in the data from this paper, is that oftentimes patients who identify themselves as Black will travel further to go to a lower quality hospital. And I think there's an opportunity in claims data to at least objectively identify that there are some hospitals where patients are right next to them but don't go there for care. And there's something to be said about the level of hospital and community engagement that a patient might be willing to travel around that hospital, or a bypass phenomenon, to go to a lower quality hospital for the same procedure. So I think there's an opportunity of the data there. And I know some of the national quality and ranking organizations have explored the idea of saying what percent of your hospital case mix represents the community around your hospital, and should that be integrated as a quality measure. That's up for debate, but at least being considered, and I think this data helps add to that discussion.
I want to close with a hypothetical for you. I don't get to do this very often, so I was excited that I could come up with a, well, what if kind of thing. If I were a CMS administrator, what would you recommend to me based upon the findings from your study? What do I need to do differently?
It's a very provocative question. I think what our study demonstrates, and we were alluding to this earlier in the conversation, in the era of big data and having so much granularity in our data and its availability, I think what we've demonstrated is that if one wanted to, there is certainly the data and the tools to develop a patient-facing portal of sorts that patients can utilize to more reliably shop for a high-quality hospital in their area. And what I mean by that is these star rating systems can certainly be extrapolated to a myriad of procedures and not just a general star rating for a hospital. So one can envision a patient going to cmscompare.com and typing in their geographic area and the certain operation that they're looking to have, and the tool could rank all the hospitals in their area for them. We have the data to do that. I think we've demonstrated that with the study, and that's certainly something that's more useful and more transparent for patients.
I love that tailored approach by Dr. Diaz as described, and would even add another layer that you could build in patient preferences to that search to say, I'm willing to drive up to an hour and I want to be able to see a provider that is race concordant with myself. What is the best option for me within those filters or otherwise, to try to bring the patient's voice into it in addition to an outcome?
Sounds like we've really got some great opportunities to enhance the patient-centeredness of what we've got right now and where we can and should be moving. Dr. Ibrahim and Dr. Diaz, I want to thank both of you for your time today. I really enjoyed our conversation.
Thank you so much, Dr. Cochran. Great to be here.
Thank you so much. It was an honor.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.